Future leaders of the free world.
We have another lecture for you, week 10.
Enjoy.
Personality disorders.
Yeah.
And so we're going to go over the introduction. We're going to go over cluster A. This is going to be a two-part video. So this week we'll be doing the first part. The next week we'll be doing clusters B and C. As per the usual, what should we be doing while we're watching this video?
Taking notes.
That's right.
Take out your notebook. Take so many notes. Take notes. Yep, notes on notes. You know, make sure you're getting those slides out. Make sure that you're asking questions via email with Psych238 in the subject line. Make sure you're watching the study videos on the Compass page. And if you need any additional help, you can come to the in-person discussion sessions. Without further ado, let's get going into our lecture. But first, a brief word from our corporate sponsors. Wow, that was so great.
Wow.
Wow.
What an awesome sponsor.
I am so thrilled with this sponsor.
I can't believe we got that sponsor to pick up our lecture.
Wow.
That's amazing.
It's a little beneath me, but it's okay.
It's okay. It's no problem. Not demonetized. Okay, so now that we're done with all that, let's go ahead and get started. Now, just remember, some of these videos contain YouTube clips that I might cut out because my channel's fully demonetized. That Oprah clip just ruined me for the DID lecture. We had that Oprah clip. It ruined my channel. Oprah hates me. Harpo Productions is going to, we won't talk about that because they're going to give me an anti-defamation lawsuit. So now we're going to go ahead and get started. We'll jump out the way. So just make sure you're taking notes and we'll be back. Hello class. This is going to be our week 10 lecture on personality disorders. We're going to go over intro material, then cluster A, and then week 11, we'll go over cluster B and cluster C personality disorders. So throughout the lecture, you're going to see these slides come up. These slides are going to let you know where we are. So we're going to start with the definition and models of personality. Then we're going to go down to cluster A. Next week, we'll do cluster B and cluster C. So let's get started by talking about what personality is. So we all seem to understand different people might act the same way in similar situations. And we also understand that it is clear that certain people might act differently in different situations. However, if you look across an individual's responses to all situations, usually some sort of pattern of how they think, feel, and behave emerges. And these patterns are known as personality. So there used to be a big distinction between personality disorders and other forms of psychopathology in terms of like stability. But more recent research has found that personality is equally or at least similarly stable over time. General personality research indicates that traits are stable over time, especially with older people, but personality can change. So for example, some students might report different characteristics at the end of college as opposed to the beginning of college. So like most psychological constructs, personality is thought to be a function of biology and environment. Personality disorders are going to be enduring patterns, inner experience.
So one of the things that we were talking about is how even though personality disorders are by definition patterns of behavior and thinking across time and context, other psychological disorders may have the similar characteristics. For example, major depressive disorder can last a very long time and can look in a way like a personality disorder.
That's right, because you can have so many major depressive episodes for, they're back to back for a very long time, and it can definitely feel like, this is something that is always occurring with you. However, when we're talking about personality disorders, we were talking about how with personality disorders, you are always symptomatic to some degree. So remember, when we were talking about being in remission, that's when, you're not having symptoms for an extended period of time. So with personality disorders, since these are so stable, even though there might be certain periods of time during the day where you might not appear to be symptomatic or be struggling with your personality disorder, there will be other periods of time during that day where you are going to be symptomatic. And depending on what context you're in, it'd be more obvious in other contexts. And so what we were talking about with things like major depressive disorder and alcohol use disorder, even though these disorders might come back or you might be symptomatic for like your whole life, typically there are periods of remission, periods of without the symptoms. And with personality disorder, disorders, those symptoms are going to be around pretty much your entire life.
Yeah.
All right. Experience and behavior that deviates markedly from the expectations of an individual's culture. So this means that these kind of patterns, these kind of behaviors, they're enduring, they're inflexible, they tend to be consistent across different situations over time, and they do cause significant stress and impairment. The source of distress is not the symptoms themselves, but people's reactions to the personality characteristics. So this creates impairment in that it typically interferes with their ability to get along with other people and perform social roles more than just peculiar habits or eccentric behavior. Pathological personality traits are associated with an increased risk for subsequent development of other mental disorders, like negative emotionality. High neuroticism often predicts a later onset of major depression or anxiety disorder, and paranoid and schizoid personality disorders sometimes precede the onset of schizophrenia. And comorbid personality disorders can interfere with the treatment of a disorder such as depression. Now, when we look at the onset of personality disorders, the pattern of behaviors that lead to personality disorders can be traced back to adolescence or early adulthood. Most mental disorders are ego dystonic, which means that the person experiences the distress and the disorder itself is something outside of the norm of their lived experience. However, when it comes to personality disorders, these are going to be ego-syntonic, which means that the individual themselves does not experience distress based on the symptoms of their disorder. So for ego-dystonic, let's look at something like anxiety or depression, right? So the symptoms of anxiety, the worry itself, is distressing. When we think about depression, the depressed mood, the anhedonia, is distressing to the individual. But when we look at somebody with a personality disorder, it's only the consequences of the disorder. This is the emotional distress and the trouble in interpersonal relationships that causes the distress. But the symptoms of the disorder itself, these are the personality characteristics that lead to the emotional problems, are not distressing to the individual. So an individual with a personality disorder will not feel like their personality disorder is a problem. So let's look at somebody who has narcissistic personality disorder. They might be upset because they don't have many friends, but they're not upset that their personality disorder is causing this issue. They're upset because they think that, I'm better than everybody and others just don't appreciate me for who I am. And if other people just appreciated me or could see me for who I am, then, I'd probably have more friends. Okay, so let's do a little bit of quick review about ego dystonic and ego syntonic. So anhedonia is a characteristic of some traditional mental disorders as well as some personality disorders. However, its presentation in these are different. Anhedonia in one disorder as a symptom is distressing because a person wants to be able to experience pleasure but cannot. Anhedonia in another disorder as a symptom is not distressing because the person does not really care about whether they gain pleasure from activities. It's just who they are. The first symptom disorder is an example of blank, whereas the latter is an example of blank. So is the first one ego-syntonic and ego-dystonic? Or is it ego-dystonic, ego-syntonic? All right, what do you think it is? So the answer is going to be B, ego-dystonic. Because remember, with ego-dystonic, the individual experiences distress. With ego-syntonic, the individual does not experience distress from the symptoms. They only experience distress from other people's reactions to their symptoms. So personality disorders are not particularly common in the general population. Most personality disorders have low prevalence in overall population and a much higher prevalence rate in clinical samples. There are higher rates of personality disorders in clinical inpatient settings. So this is where people are living in a hospital or a clinic. And the most common personality disorder in these settings is going to be borderline personality disorder. However, if you are a therapist working with people, there's a good chance that personality disorders will be a concern for you, especially borderline personality disorders, because of the interpersonal difficulties that personality disorders cause. Now, there is a high level of comorbidity in personality disorders. So, for example, the average number of personality disorders per client typically ranges between 3 to 5. At least 50% of people who meet criteria for one personality disorder also meet criteria for another. And studies show that borderline personality disorder has an 80% comorbidity rate with other personality disorders. Now, this suggests that borderline personality disorder might be too broad, and this might mean that is too heterogeneous of a category. So now let's talk about the big five. So this is Ocean. This is the way we look at personalities. So this is actually fairly self-explanatory. There are 5 factors, and people often fill out these personality inventories online, or you might have seen them in jobs, or you might have seen them on BuzzFeed. And these measure different factors in social psychology experiments. So researchers have tried to kind of like pin down what makes a normal personality, and so that these 5 factors kind of show what is considered to be the normal factors of personality. So you have openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. Now, all of these are considered dimensions, so everybody will fall somewhere along the lines of these. And personality disorders tend to arise when people fall at the extremes, either being too high or too low with all these categories. All right, so here's a little bit of review right here. So Susie fills out a personality questionnaire and strongly endorses behaviors and feelings characterized by cynicism, an unwillingness to help others, and aggression. Susie seems to rate low on, let's take a look right here. That's right, agreeableness. Now there is continued research on personality disorders, and there is a new group, or I should say within the DSM-5, a new group was created. This is the personality disorder group. Actually, this existed before, but they wanted to come up with some new guidelines to look at the big 5 as a dimensional model. Now, this actually was rejected for use as a primary system, pretty much because it lacked sufficient clinical utility. So this was placed in the back of the DSM-5 under emerging measures and models to encourage more research to try to set up a dimensional model for personality disorder. So when we're trying to determine if someone has a personality disorder or not, we want to take a look at a couple aspects of their life. We want to look at the self and interpersonal relationships. So when we look at the self, we want to look at their self-identity. So this is going to be the experience of oneself as a unique individual with clear boundaries between yourself and others. This is going to be stability of self-esteem, an accuracy of self-appraisal, capacity for and ability to regulate a range of emotional experiences. So if an individual has problems regulating their emotional experiences, their reactions to things, if somebody has fluctuating self-esteem, if somebody does not actually have an accurate view of their self-appraisal, so then we have self-direction. So this is going to be pursuit of coherent and meaningful short-term goals. Now, this is going to be like the utilization of constructive and pro-social internal standards of behavior and the ability to self-reflect productively. Now, what is productive self-reflection? Well, there is unproductive self-reflection, which is, I'm so dumb, I'm so stupid, I made this mistake, I said this thing, I shouldn't have done it. I'm kind of like, you're just sitting there thinking about it, ruminating about these mistakes you made in the past. Now, productive self-reflection is, let me see what I did here. I made some mistakes. I could have done better at this. How can I improve for the next time? This is how you improve yourself. Now, with someone with a personality disorder, they will not have the ability to self-reflect productively. So let's look at interpersonal relationships. So one of the things we have right here is empathy. This is going to be comprehension and appreciation of others' experiences and motivations, tolerance of differing perspectives, and understanding the effects of one's own behavior on others. Empathy right here is something that interpersonal relationships are built on, and individuals suffering from personality disorders will have difficulties with empathy. We also have intimacy. So this is going to be the depth and duration of connection with others, desire and capacity for closeness, mutuality of regard reflected in interpersonal behavior. So this kind of intimacy is something that we experience with romantic relationships, with familiar relationships, with friendships, and a lack of intimacy or a desire or like a lack of a desire for intimacy can be indicative of a personality disorder depending on the distress and impairment that it causes in an individual's life. So right over here we have some dimensional models of personality based off of some of the ocean characteristics. So right over here, let's look at like negative affectivity, right? So this would be a pathological form of emotional stability. So on one end, we have personality disorder. In the middle right here, we have normal traits. So on one end, if I have too much negative affectivity, leads to a personality disorder. But also, if I have too much emotional stability, this could cause a personality disorder as well. Let's think about detachment. So if I am too detached from social relationships, from social functioning, this could give me a personality disorder. But also let's look at extroversion. Too much extroversion can be a bad thing. And we can do it right down the line from antagonism and agreeableness. Being too antagonistic, this can lead to personality problems, sorry, I should say relationship problems, so being indicative of a personality disorder, but also being too agreeable. If you're too agreeable, you can become too codependent on other people, and that would be a personality disorder. Now let's look at disinhibition versus conscientiousness. So disinhibition is I don't really think about things. I'm very impulsive. I do what I want. I do what I feel. I want this. I want that. And I'm not really putting a lot of thought into it. Whereas conscientiousness is maybe I'm overthinking things. I'm being too deliberate about too many things. Maybe something as simple as grabbing water rather than just picking up the water. I'm trying to do all this weird stuff with it. Let's talk about psychoticism versus lucidity. So psychoticism is going to be these unusual beliefs and experiences, and lucidity is going to be, being present in the moment. But maybe you could be too present in the moment, it could be maladaptive. So it all depends. Depends on the situation, depends on the person. So here's a little bit of review for you. So someone with antisocial personality disorder might be more likely to pursue activities that are likely to get them in trouble without considering the consequences. For example, someone with antisocial personality disorder may be more likely to shoplift, get into physical fights, and drive recklessly. What characteristic of the dimensional model does a personality of this type map onto? All right, which one is it? Boom, there we go, disinhibition. So here are some advantages and disadvantages of a dimensional model. So as you can see right here, the dimensional model allows us to capture more information because rather than having someone to meet a specific criteria, they can have some level of dysfunction, some level of a characteristic that might lead to a diagnosis. And we can see this helps us out with high reliability. It can help us out with comorbidity. It can get rid of these arbitrary cutoffs. As you know before, subthreshold number and subthreshold level of symptoms can still cause significant distress and impairment. And that's the same thing with personality disorders. So by removing arbitrary cutoffs, we can help more people. Now, this could be a problem as well. So the disadvantages are this is too confusing. It's brand new. You have to get trained on it. Doesn't really have any clinical meaning. Like what do these numbers mean if you can't interpret them appropriately? It could be too complex. So since you have a dimensional model, you have a seemingly infinite number of options or, results you might arrive at, and there's no real consensus of what model to use. Some people like the 5-factor inventory. Some people want to propose a 6-factor by adding schizotypy. It can be very confusing. So advantages, it makes it really easy for you to communicate where things are going on. It makes it really helpful for you to make decisions. It allows us to understand that we all can contain some kinds of these behaviors, so we reduce the stereotyping. But disadvantages, it's brand new, it's very complex, and it can be very cumbersome to use, and the clinical utilities in question. We have 3 clusters of personality disorders. We have cluster A, odd and eccentric behaviors, cluster B, dramatic erratic, and cluster C, anxious avoidant. Now, the criteria is going to be based on the symptom counts and how they're presented itself. So similar to other DSM-5 categories, an individual can have one or more of these disorders. So this is what we're looking at here for the DSM-5. This is what we use. We use the categorical classification for personality disorders. So what this means is that we have a familiar system that everybody knows how to use. We have advantages and disadvantages. This can be something that you can train somebody on. It's a manualized treatment. It's easy to communicate the information back and forth because since we have these categories, if I tell you someone has a borderline personality disorder, you know what that means. You don't have to think about it. You understand those kind of traits, those characteristics. This is going to be very good for clinical decision making. It's very easy to administer these interviews. They're in a yes/no format. That's through the structured clinical interview of the DSM-5. With personality disorders, looking at a categorical classification, we do have some disadvantages. So those arbitrary cutoffs. So for example, if you need to have 5 of 9 symptoms to meet criteria, but you only have 4 of 9, you don't meet criteria, you don't receive the diagnosis, but you still have 4 of these symptoms. That can be a big problem. Now, when we think about categories of personality disorders, there is some question to inter-rater reliability and also the validity of some of this. So we have like high comorbidity. So some people think that maybe the comorbidity is too high because these disorders haven't been clearly defined. A lack of research. So a lot of the categories in the DSM-5 really don't have any explicit theoretical rationale for why this personality disorder exists. So I'm talking specifically about personality disorders in the DSM-5 right now. And then when we think about the most frequently diagnosed personality disorder, which is personality disorder not otherwise specified. What that means is this is somebody who has all these different symptoms. They have a lot of symptoms, but don't actually meet criteria for a specific personality disorder. So they're diagnosed with a personality disorder not otherwise specified. So what this indicates is that maybe there's some confusion in the DSM-5 and more research needs to be done to figure out if these personality disorders are valid constructs. So let's talk about the role of culture and personality. So as you know, culture plays a large role in determining what is appropriate or acceptable at a given place and time. So culture is combined of a lot of different aspects. We have a little picture right here you can take a look at. The behaviors or styles of interacting are going to be considered normal within some cultures, and they might be considered inappropriate within another. So in defining personality and personality disorders, we need to consider the possibility that certain personality characteristics may be more common in certain cultures. So what works in one culture may look like a disorder if the individuals are transplanted into a different culture. So for example, some cultures have different expectations for or different sex differences in behavior. So some cultures expect males to act one way and females to act another way. So in our culture, America, it is okay or it is normal to see males and females expressing a wide range of emotions and a wide range of behaviors. But in other cultures, if you were to see a male and female partner having an argument and the female partner was yelling at the male partner, some cultures would have a problem with that. So we have to take that into account when we're thinking about personality disorders. Because even though we might feel a certain way about our culture, we cannot take our culture and then view other cultures through the lens of our culture. We can't force people to follow the culture of our country or whatever we think that other people should do. But we have to understand that other cultures have their own ways, and we have to respect that. Now, there's individualism versus collectivism. So some cultures might vary in how they value independence versus self-reliance, and versus working for the common good and self-sacrifice. Context is also important. So certain personality traits might be expressed only under certain challenging circumstances that require a particular response. For example, let's think about aggression. Aggression is going to be typically acceptable if you're a soldier on a battlefield, if you're a football player, or other kind of athlete, or if you're a mixed martial artist. If you're in the cage or octagon, wherever they call it, punching someone in the face might be okay and rewarded, but punching somebody at the bar because you were drunk might not be. So you have to keep the context in perspective. Additionally, you want to think about how social circumstances determine whether a behavior will be assigned a positive or a negative meaning by other people. All right, so we talked about two different models for conceptualizing personality disorders, which both have their own advantages and disadvantages. So one advantage of the blank model is that it is familiar to clinicians, but the blank model better captures more information about the patient and reduces the risk of comorbidity. So you have the categorical model, dimensional model, or dimensional model, categorical model. All right, let's see what the answer is. There we go. So the categorical model is familiar to clinicians. Remember, categories are buckets. Those are discrete little sections right there. So if you fit this category, you have this disorder, whereas dimensional model is going to be a line, it's going to be a continuum. So you could exist somewhere along that continuum, and at some point in time, those behaviors become maladaptive. All right, so the DSM-5 describes 10 types of personality disorders broken into 3 categories. We're going to get into more details on these a little bit later, but for right now, you should know that the 3 main subcategories are cluster A, odd and eccentric, cluster B, emotional, dramatic, and erratic, cluster C, anxious or fearful. So these are going to be the 3 categories of personality disorders. And as you can see right here, we have those personality disorders listed under each category. If you go to the DSM-5 online, you'll see more about this. So now we're going to go ahead and move ahead to cluster A personality disorder. So there's going to be 3 personality disorders contained within cluster A. This is going to be paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So to meet criteria for any 3 of these personality disorders, the pattern of behavior cannot occur exclusively during a psychotic disorder like schizophrenia, bipolar disorder, or depression with psychotic features. Although the DSM-5 indicates that individuals meeting criteria for these 3 personality disorders can be psychotic for a few hours at a time. So all 3 of these share a similarity with the symptoms of schizophrenia. So these types of personality disorders may represent behavioral traits or interpersonal styles that precede the onset of full-blown psychosis. So right over here we have a triple Venn diagram that talks about the specific characteristics and the common characteristics of these different personality disorders. And I'll leave this up here for you so you can take a look at it. So go ahead and pause, look at the slides, see what you think. But if you see, all three of these personality disorders have several things in common. They have impaired social relationships and few very close people. So what that means is these relationships, there's only going to be like a few friends that are going to be very close. And when it comes to other people, like having like extended family networks, extended friend networks, these individuals are going to have a difficult time maintaining those larger relationships. So paranoid personality disorder is going to be pervasive distrust and suspicions of other people. So this means that the individual perceives the motives of others as being malevolent. So you're going to need 4 more of the following symptoms right here on the list. Now, an individual with paranoid personality disorder might be hostile, stubborn, sarcastic, have an excessive need to be self-sufficient, a strong sense of autonomy because they don't want to rely on other people. Individuals with paranoid personality disorder might be so amazed when they see loyalty, because they just can't believe that someone would actually be loyal to another person. Someone might get in trouble and they'll assume that maybe somebody either set them up or their friends or associates won't come to their aid or help them out. Individuals with paranoid personality disorder might interpret an honest mistake as a deliberate attempt to sabotage or shortchange them. This individual might view casual humorous remarks from a coworker as like a serious attack on their character. Compliments paid to them are going to be misinterpreted. So for example, if someone compliments them on like a new purchase or acquisition, an individual with paranoid personality disorder might think that the person is insulting them or is being very selfish. An individual with a paranoid personality disorder would also be very unforgiving for mistakes and slights in the past. They're going to hold grudges for a long time. Now, it's important to understand that there's going to be no justification for the person's mistrust of others. Right? So events that have nothing to do with the person are interpreted as being threats. So for example, if your neighbor has a dog that is barking, this could be seen as an attempt to annoy them. Remember, this paranoia is going to generalize to all aspects of the individual's life. So it's going to be important to understand that individuals with paranoid personality disorder do not confide in others, and this makes treatment very difficult. So it should be noted that the suspicions of people do not reach delusional proportions. So they are not typically severe enough to be considered obviously false or preposterous. So the suspicions are realistic in nature and they probably could happen, but they're really unfounded. There's no really real justification for this. Okay, so what is the key factor a clinician must determine or look for before making a diagnosis of paranoid personality disorder? A, B, C, or D? Take a look at these options here. All right, take a look at them. Which one is it? There you go. It's A. The paranoia is unjustified. Remember, the paranoia should be unjustified. So I'm going to pause that real quick and just to put that out there that the paranoia has to be unjustified. So you really couldn't give somebody paranoia or talk about being paranoid if they're worried about their partner cheating, but the partner is actually having an affair. And they're like finding like a bunch of text messages and emails and things like that.
So for example, Martin Luther King would have been not diagnosed with paranoid personality disorder if he was to believe that the FBI was after him.
Exactly. So someone who's like there are people who are being chased by the police or harassed by the police or being surveilled by the FBI. And sometimes they might express that and people might view that as, them being paranoid. But if it's actually happening, then it's not really paranoia. And to some extent, if you have a Facebook account, like someone's tracking everything you're doing. So like,
Well, it depends on how much your behavior changes because you think like the extent to which they're paying attention to your specific Facebook profile.
So then you could almost have precautions that are out of alignment or incommensurate with the actual threat of
With
Facebook.
the actual threat, yeah.
So like if I started like, putting like foil around my room or blacking out my windows or like all sorts of other things or like, breaking my SIM card every day and getting a new SIM card, then it could be like, oh, okay, maybe this is too much.
Yeah.
All right, that's good. So if I live in an apartment complex and the little kids have been slashing tires for weeks, and then my tires get slashed, and I think maybe the little kids who've been slashing tires for a week did it, that's not being paranoid because my paranoia is justified because people have been slashing tires in my apartment complex for the past few weeks, and now my tires are slashed, and I think the kids did it. Okay. So let's talk about schizoid personality disorder. So this is going to be a pervasive pattern of detachment from social relationships and restricted range of emotional expression. So you're going to need 4 more of these symptoms. Go and take a look at the symptoms right here on the list. Now, people with this disorder typically don't marry or express a desire for sexual intimacy. They may react passively to adverse events, so they appear to be emotionless and often do not express anger, even when provoked. They often report that they rarely experience strong emotions like joy or anger. And in contrast to paranoid personality disorder, they are generally not suspicious of other people, rather they are indifferent to other people. So take a look at some of these symptoms here. These would be the symptoms you want to look for schizoid personality disorder. So based on what we know about schizoid personality disorder, what big 5 characteristic do you think a person presenting with this disorder might score the lowest on? All right, take a look right here. There you go. It'll be one of these 3: openness, conscientiousness, or extroversion. All right, so now we have schizotypal personality disorder. So this is going to be pervasive interpersonal and social deficits. So they're going to be marked by acute discomfort with and reduced capacity for close relationships, cognitive or perceptual distortions, and the eccentricities of behavior. So this is often thought as a milder form of schizophrenia, and some individuals or some researchers have actually proposed moving schizotypal personality disorder to Axis 1. Now, ideas of reference. This is going to be describing the phenomena of an individual's experiencing innocuous events or mere coincidences and believing that they have some kind of strong personal significance. So for example, let's say you get up in the morning and you go outside and a car drives by and it's playing your favorite song on the radio, and you hear the favorite song and you feel like this is going to be a good day. I heard my favorite song. Well, sure, that's a typical experience that people have, right? However, let's amp that up a bit. So I'm going down the stairs in front of my apartment complex. A car drives by, it's playing my favorite song, and I say that is a sign from God that today's the day. Today's the day that I achieve all the dreams that I've had. I achieve all my personal goals and desires. This is the day. You see that? That is a strong personal significance that is outside of what would be deemed normal or acceptable. Of course, this might vary based on society, based on religious or cultural views, but remember, these symptoms are going to cause distress and impairment. They're going to cause life disruptions. So let's talk about some of the characteristics that you might have for a schizotypal personality disorder. First of all, while I'm going with these characteristics, these are not the same thing as the symptoms, but they might be very similar, right? So remember, for these symptoms listed right here, we need 5 or more for schizotypal personality disorder. And make sure that you're going to the DSM-5 to take a look at these symptoms. All right, now, before I get into some of the characteristics, let's talk a little bit about the family history of psychosis. Now, those with schizotypal personality disorder are commonly relatives of individuals with schizophrenia. However, the vast majority of individuals with schizotypal personality disorders still do not have relatives with schizophrenia. So it would be false to say that most individuals with schizotypal personality disorder have relatives with schizophrenia. So here are some of these characteristics. You might have an individual who might have disorganized thoughts or disorganized responses. So for example, their responses might be overly concrete or abstract, or words are applied in strange ways. So some of that disorganized speech we talked about before. So I was not talkable at work. That might be an example of this. An individual might have cognitive perceptual symptoms like being superstitious, being preoccupied with paranormal, like ghosts, spirits. These individuals are more prone to joining cults or being the head of cults. They might think they have magical powers, control over other people. They might be suspicious and have paranoia, but you do not need to meet criteria for paranoia in order to get the diagnosis. Whereas when we think about like a paranoid personality disorder, remember the paranoia is a central feature. So paranoia might be present in schizotypal personality disorder, but it's not necessary. It might be an unusual manner of dress. This could be unusual mannerisms as well. You could think about social anxiety because these individuals understand that they don't fit in. You might have magical thinking, like thinking about special abilities, looking into the future. We talked about ideas of reference, taking these small, innocuous, coincidental events being very significant, having a strong personal significance. You can also think about illusions. So illusions, these are going to be things like feelings that someone else is in the room. This is going to be different from perceiving that someone else is in the room. So we talk about hallucinations, where you see somebody who's in the room with you that's not actually there. And illusions is going to be different. Illusions, you're going to feel like there's someone in the room with you who's not actually there. They also might think that someone is calling their name, but no one's actually there. And this degree of conviction, this degree of certainty that this is a real auditory or, visual event is going to be much less than schizophrenia patients. So the degree of conviction in schizotypal personality disorder is much less than schizophrenia patients. So just like when we talked about schizophrenia, you could think about schizotypal personality disorder symptoms being present in 3 categories. I'm going to go ahead and leave this up here for you. So we have the cognitive perceptual symptoms, the interpersonal symptoms, and disorganized symptoms. So this is going to be a way you might want to group the symptoms for schizotypal personality disorder. Now, I do want to draw a good or a strong delineation between schizotypal personality disorder and paranoid personality disorder. It is important to understand that even though you might have similar symptoms between schizotypal and paranoid personality disorder, paranoid personality disorder does not contain any cognitive or perceptive symptoms. So that's the odd beliefs, the magical thinking, the ideas of reference, the unusual perceptual experiences. These are not contained within paranoid personality disorder. So a therapist administers an interview with Marcus. Marcus describes having very few hobbies and not getting pleasure out of anything, including social relationships and dating. As a result, he has no friends other than his siblings. He also occasionally gets the feeling that spirits are trying to send him messages through the radio. Marcus's affect is flat in his appearance, showing no facial expressions or changes in his vocal intonation during the entire assessment. What diagnosis seems to best represent Marcus's experience? So let's take a look right here. A, paranoid. B, schizoid. C is schizotypal. D, B and C. E, on the above. Let's take a look right here. There you go. Schizoid personality disorder. Does it make sense? Email office hours. What word should you associate with schizoid personality disorder to help you remember the difference between schizoid and schizotypal? A, avoid. Annoyed. Employed. Devoid. Freud. All right, take a look. A, avoid. Remember, schizoid, avoid. All right. So what characteristic is shared among the 3 cluster A personality disorders? So we have social anxiety, impaired social relationships, anhedonia, paranoid ideation, hypomania. What do we have right there? There you go, impaired social relationships. So let's look at the etiology of cluster A personality disorders. So these are actually very understudied disorders. Characteristics of cluster A personality disorders are highly in common with schizophrenia. Some researchers believe that there might be some genetic risks for cluster A personality disorders that are very similar to schizophrenia. So for example, with some of the information we saw about how people with cluster A personality disorders might have relatives that have schizophrenia, but remember, a vast majority don't. Psychological factors have been thought to contribute towards the development of cluster A personality disorder. So we have difficulty with theory of mind. So theory of mind is like the ability to recognize emotions in others. Also, we might think about insecure attachment styles. So potentially result from like childhood maltreatment, abuse, or neglect. There's some other biological factors that have been thought to be associated with type A personality disorders. Fetal hypoxia, so that's oxygen deprivation during labor or delivery complications. You might think about prenatal infection or maternal viral infections. You might think about how flu risks or epidemics have an issue or contribute towards the development of class A personality disorders. So if you're born during a viral outbreak or a flu epidemic, this might increase the risk of developing a class A personality disorder or schizophrenia later down the road. And also, we want to think about seasonal birth effects. So we talked a little bit about this with schizophrenia, but if you are born during winter months or during like summer months where there's like the winter flu, summer flu, things like that, this can cause an issue. All right, a little bit of epidemiology of cluster A personality disorders. Half of individuals with schizoid personality disorder also meet criteria for schizotypal personality disorder. So as you see right here, look at some of these prevalence rates, like 2.3 to 4%, 3.1 to 4.9%, 3.9%. We see right here that paranoid personality disorder is slightly more common in males, but schizoid and schizotypal personality disorder are more common in males than females. Now, very little to research has been done to try to evaluate treatments for cluster A personality disorders. So people with this cluster tend not to be interested in treatment and are usually either urged or coerced into showing up. So they're often reluctant at best. So the particular challenge of treating people with odd eccentric personality disorders is their tendency not to collaborate with a therapist to develop goals for treatment. So right over here, you might want to look at what's the best way to try to treat somebody with these different disorders. So for paranoid personality disorder, you want to try to create a trusting atmosphere. You also want to challenge irrational thoughts, but of course you don't want to diminish the rapport you have with your client. You have to be very careful about that. And the clinician should always try to be optimistic. So individuals with paranoid personality disorder are going to be very sarcastic. They're going to be very dubious about the things that you tell them. So you want to try to be optimistic about their outlooks. Now, when we talk about schizoid personality disorder, that's going to be the more avoidant type individuals. So you want to try to help them to focus on developing social skills. And then we have schizotypal personality disorder. Now, usually for this, antipsychotic medications work, usually at lower doses when compared to schizophrenia. And similar to schizophrenia, you want to use CBT, so that's cognitive behavioral therapy, and social skills training and family therapy. This is a way to help individuals with schizotypal personality disorder get the help that they need from their family and friends and their social circles. All right, so that's going to be the end of our lecture for personality disorders. So on Compass, we have more notes, slides, and example videos. If anything in this lecture didn't make sense to you, please send me an email. Please come to office hours. Make sure you're doing the readings. Make sure you're watching the videos. Make sure you're asking questions. We're coming up towards the end of the semester, so we're past the halfway point. So congratulations, or I should say congratulations for still being here, still sticking around. Let's see what happens moving forward. All right.
So I just wanted to give a summary of what we learned today. We cover cluster A personality disorders, which is paranoid, schizotypal, and schizoid. Paranoid is the enduring belief, distrust of others and belief that people are out there to perhaps harm you. Schizoid is the avoidance of people, and schizotypal is the odd beliefs. So you can think about these three different disorders by these characteristics that they have, differentiating characteristics that they have.
Yeah, that's actually a really good point. And also, for these personality disorders, as we said in the lecture, there's a lot of comorbidity and there's a lot of overlap of symptoms. So one of the great things that we have available to you online is going to be the online DSM-5 chapter.
Yeah.
And in those online DSM-5 chapters, you're going to have all this information that goes over how to make a differential diagnosis between different personality disorders.
Okay, well, great. Yeah.
So that's it.
Yeah, that's it.
Well, there we go. So you got the emails up there. So email, office hours, in-person discussion sessions. Peace, peace, peace.